Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMGA's public policy podcast. As usual, I'm with our all-star crew, and we're having a great discussion about our question of the day. But we'll get to that in a second. Let's introduce ourselves. I'm Chet Speed, your host, and we'll go to the right today.
Hi, good morning, everybody. My name is Daryl Drevna. I'm the Senior Director of Regulatory Affairs.
Jamie Miller, Ambassador of Goodwill here at AMGA.
You just cut me off.
Yeah,
I saw that.
I did. The Ambassador of Goodwill did cut you off.
Wait, I thought we were going this way.
No, that's not Goodwillish.
I'm so confused.
Alicia, please.
Yeah.
Please go. Please go. We will look at Jamie.
Alicia Sawyer, Government Relations Assistant.
And so Jamie can answer the question right now. You're on time now.
You just got 2 minutes for me.
Jamie has a 6-month-old, so he understands that. 6, 5?
5, I think.
5 months?
Yeah.
Very nice. And my wife and daughter love the pictures, so keep sending them.
Yeah.
Very cute.
He's a happy child.
Yes.
Happy parents, happy child.
Just wait.
I'm waiting for that bad part to start. He wants to take the Subaru out or something like that.
Yeah. Yeah. Welcome to my world.
So I had a question ready for the team, and then Alicia said, no, that's a bad question, so she interjected her question instead. It just goes back to my lack of control anywhere, which Sharon mentioned also, my lack of control. Anyway, so Alicia's question today is, Alicia, why don't you go ahead?
Well, I was going to continue on the breakfast theme from our last podcast, and my question was, what is it not okay to put maple syrup on at breakfast?
Swear to goodness, we talked about this for 10 minutes before this recording.
Well, what I said was, it's not okay to put maple syrup on eggs. I knew someone who would put maple syrup on scrambled eggs, and I was never okay with it.
That was unanimous no.
That was a unanimous no.
Absolutely. My guy's, he's nodding also.
He was very upset about that. He was very upset.
Disgusting, he says.
I mean, any sort of breadish product, put your maple syrup on it. But,
Yeah,
you know,
waffles, pancakes, call that.
biscuits,
Yeah.
fair game. But like, oh, here's my, smoked salmon. Like, no, I'm not gonna.
We did say sausages.
On a
Sausage,
bagel?
right?
No.
Yeah.
Sausage is okay. We agreed
Bacon.
that, like, if it gets on bacon, that's fine. If it's on your oatmeal, that's fine. I said no to grits. You can't put that on your grits.
And Jamie, you're Southerner. Yes? No? To grits?
Yeah, you can put it on your grits.
Okay.
I mean,
I disagree.
You're from Florida.
Florida, that's not the South.
Yes, it is. I'm from North Florida. We share a lot in common with South Georgia. We're basically just the South on the coast.
That's where Leonard Skinner came from. Right?
Yeah, Leonard
North
Skinner's from
Florida,
Jacksonville.
Which is about as...
Yeah.
Thank you. Thank you.
By the way,
yeah,
the best band ever.
I
That's
agree.
next week's question.
Yeah. Molly Hatchet. Okay, all right. We're at 3 minutes, and Sharon said that's far too much. Okay, so today we're going to talk about an issue that's near and dear to both Daryl and I believe our members' hearts, and that is the topic of administrative burden, which, candidly, AMGA is going to switch to administrative waste, because all the regulations, all the statutes that impede your ability to deliver care is frankly wasteful. And that's what we're going to talk about. Honestly, this is going to be a theme of AMGA's for the next year or two. And we will ask all AMGA members for other examples of administrative waste as we work on this issue on your behalf. Just a couple of facts, as you probably already know. Doctors spend 2 full business days on paperwork, not patients. Can you imagine? Well, yes, you can imagine. Over $15 billion annually is spent on quality reporting issues alone. This is, frankly, waste. And it's an issue we're going to hammer on for the next 24 months. We had an AMGA macrobiota task force, which actually dedicated an entire chapter to the idea of administrative waste. And I'll jump in and ask Dale to talk about that, because he was a staff director of the task force, and I think you know this stuff as well as anybody.
Yeah, no, it's really exciting. So we officially launched our macro value task force and the recommendations. The report is online. We've distributed it to the Hill. Press releases out. The whole shebang's out. And as part of that process, we identified 6 pillars that really need reform and examination. You've got enhance patient engagement, improve health outcomes, protect patient dignity at the end of life, support rural and underserved populations, and find a sustainable reimbursement model. And one of the ones we're going to talk about today, one of the pillars is addressing and removing regulatory and legislative barriers, which if you want to characterize it as a barrier, that's fine. But the more we thought about it, the more we looked at these examples, right, this isn't a barrier. This is just flat out waste in the program. We're putting time and energy into things that aren't moving the system forward, aren't benefiting really anyone, but they're these check the box exercises that are mandated from the government. So we have to do them, but they're not adding value to anything.
When a physician spends 800 hours a year on quality reporting, that's not adding value
Correct.
at all. And that is a fairly well-researched statistic. So let's talk about some real examples of waste and some things that we're going to really harp on with both Congress and HHS. Alicia, you want to take the shot?
Yeah, so let's talk about prior authorization. Right now, if a doctor wants to order an MRI for a Medicare Advantage patient, they often have to get permission first. That sounds reasonable, right? Well, except over 80% of denials that are appealed get overturned. And this means the care was medically necessary, but the patient had to wait, sometimes weeks. The doctor's office spent hours on phone calls and paperwork. The insurance company spent money processing and then reprocessing. And it's a waste. And one AMJ member told the task force they now automatically schedule MRIs 14 days out. Not because patients need to wait, but to give them time to fight the inevitable denial. That's waste.
That's amazing.
Yeah, no, here's another example for you. DemiPost, I used to work on this issue a lot before I joined AMGA. Say, a patient needs a walker. Like Alicia said, pretty simple, right? Not in Medicare's world. The doctor needs to document a face-to-face visit that occurred within 6 months, write a detailed prescription with specific instructions, sometimes provide additional documentation about the patient's condition. All of this has to be provided to the medical equipment supplier, and then they have to keep it for potential Medicare audits. Multiply this by every piece of a medical equipment: wheelchairs, oxygen, hospital beds. The task force heard from members. They have spent millions on staff whose only job is to manage these requirements. You can say, is this preventing fraud, or is it just flat out waste in the system?
Interesting you mentioned that, because my father is homebound,
Right.
cannot leave the house. To get a skilled nursing visit at his house, he needs to go to the doctor.
Yeah.
But he's homebound.
He's homebound.
So how does that make sense?
I mean, I read Catch-22.
That's right. Milo Mendebender.
Major.
Great book.
Yeah, it's fun. At least you're looking at it, it's like,
Yeah,
I'm adding that to my reading list.
oh yeah, no,
it's a book.
it's a
I know it's a book. I've
paper.
heard people say, like, oh, that's a catch-22 before.
When you say people, you mean like old people.
No.
Like the people around her.
Yeah.
Jamie, how about you?
Quality reporting. I know Chet mentioned that $15.4 billion figure. That's what medical practices are facing every year to report these measures to Medicare and other private insurers. Here's the big problem is AMJ members are keeping track of hundreds of different quality measures for different payers. Many are duplicative. Many are process and not outcome oriented. So if you think about when you go see the doctor, and I'm not calling out any individual doctor out here, but do you notice that they look at the computer screen a lot? They're looking at their EHRs. They're not doing that because they want to. They're doing that because they're becoming clerical individuals. They're putting in all the information instead of having the opportunity to talk to you. We actually had a survey a while back from our consulting division, and they asked our members, about like how many FTEs are you hiring to deal with these administrative burdens, and they're saying 14 FTEs per 100 clinicians, and I think that's a problem because hiring at least 4 or 5 per 100 FTEs are actually doing this quality program. And I wonder, Daryl, do you think it's accurate to say that the administrative burden is administered by the administration?
Whoa, that's accidents, not alliteration, right?
Sorry.
I'm trying to unpack that question. Actually.
Yeah, it was too many. It's like not. Like, I think the question you're getting at is why is this happening? And it's just there was a problem, so we implemented a rule, and we tend to overcorrect sometimes. And it's we're looking to prevent any sort of potential fraud. And while that on paper makes sense, and we want to make sure that Medicare is doing what it can to be protective of taxpayer dollars, we've created this rubric machine, this labyrinth of other words, Byzantine regulations that really make it incredibly difficult to practice medicine.
Yeah, and that's why we need to get involved, our members.
Exactly.
Yeah, indeed. Other barriers that the members are facing?
One of the ones that always sticks in my craw a little bit is the SNF 3-day rule. And so Medicare won't pay for skilled nursing facility unless you've been in a hospital for at least 3 consecutive days. So even if your doctor thinks you'd better recover, get the care you need is in a nursing facility, Medicare won't pay for it unless you spend 3 days in the hospital first, which obviously that costs way more. This rule was created back in the 60s when the standard of care was, frankly, longer hospital stays. Today, it just keeps, expensive hospital beds, folks in these beds longer than necessarily. So I think this is just waste in the system. You've got unnecessary hospital costs, delayed recovery, and potential bad outcomes for patients because of these extended hospital stays.
Yeah, that is a tough one, especially that's what 1965 rule. That means it's 61 years old.
Yeah,
maybe time for reform.
Yeah, and I think, it's one of those things where I think everyone's come across this in their own lives. I remember talking to a charge nurse about my grandfather. It was like, make sure he stays as an inpatient for 3 days because he needs skilled nursing care. She goes, how could you possibly know that rule? Like, don't trust me. I know the rule.
That's right. 42 CFR.
Yeah.
I'm just kidding. Okay. Others, Alicia?
Yeah, and so another big one is related to annual wellness visits. Medicare will pay for an annual wellness visit, which is a great preventative care benefit for all patients, but the requirements are so complex that many doctors honestly just avoid offering them. And you have to create a personalized prevention plan, review a detailed health risk assessment, collect extensive data, which most of it's already existing in the patient's record, document everything in specific ways, and it's part of that specificity that is so much extra labor, it's waste. We had a task force member say that if a patient asks about their diabetes during the wellness visit, we either can't address it or we trigger a co-payment for what was supposed to be a free visit. That's waste. Doctors spend more time on documentation than actual patient care, and many avoid offering these visits entirely as a result.
Yeah, agreed. Jamie, others?
Telehealth restrictions. As you all recall, during the COVID pandemic, Congress and CMS waived certain restrictions, so telehealth blossomed and became a expectation of patients. I mean, you heard in previous podcasts, Congress has had to extend those waivers because they cost money. One task force member said the possibility of losing telehealth has already created a chaos in our endocrinology and behavioral health departments. In past, we've heard from members saying, like, if this patchwork, if you all remember in November, the government shut down, a lot of members were like, are we going to get paid to do this service? And I think what doesn't get talked about a lot is the economic impact of telehealth. Beyond people getting access to care, those people may have caretakers that need to take time off of work to go drive an hour and a half to see their provider. And telehealth allows a lot more people to be able to contribute to the economy and also help take care of their family member and do everything that's right for the patient.
All right, that's great. So we have solutions, right, team?
Yeah, we have solutions. One of them is to reform quality measures. Stop requiring hundreds of different measures. The task force created a value measure set that is just 14 outcome-focused measures that actually matter to patients. And the impact is that it would reduce the $15.4 billion annual cost while actually improving quality by letting doctors focus on outcomes instead of data entry.
Yeah, that was a good measure set.
Yeah, no, I think it all comes down to like, let's modernize these documentation rules, right? Eliminate some sort of redundant requirements. If the information is already in a patient's medical record, don't make the doctors document it again in a specific or special Medicare format. We talked about DME a little while ago. Stop requiring separate Medicare specific orders when the medical record clearly already documents the medical necessity.
Yeah, and on the telehealth, that needs to be a permanent solution, not a patchwork where Congress comes in every couple of months and decides whether or not patients get access to their provider through telehealth. I think this is the 6th year that we've had this waiver of these geographic restrictions. And I think, honestly, Congress has to extend these permanently because our providers need to invest in this infrastructure and this technology for their patients, specifically those ones with mobility issues or reside in rural communities, so they can access care. And there's been multiple studies to illustrate that telehealth does not increase the cost curve. It actually, it actually gets patients access to care and potentially reduces ER utilization and other more expensive access. More providers.
Great.
And I think that access point is really the thing. Everything we're talking about here is about improving and streamlining access to care. So if you look at our task force recommendations for something like prior authorization, faster decision times, right? Instead of 48 hours for standard requests, 24 for urgent, instead of like the 3 days that payers currently have under the current system. Can we automate approvals if a payer misses a deadline? And eliminate prior authorization in high-value care models. The entire point of a high-value or value-based care model is appropriate utilization, right? They're not going to order unnecessary care when they're accountable for the cost and quality in this model. And Elisa mentioned this earlier. Here's a system where 80% of denied authorizations are overturned on appeal. It's simply that's a low-hanging fruit that I think is just waste in the system that we can clean up fairly simply.
Yeah, well, let's hope so. And this administration has talked about the need to eliminate regulations that impede care delivery. So we should have a pretty willing audience within this administration, HHS. Is that fair to say?
Yes. Okay. Yeah, they've had several RFIs out. I think they're very interested in addressing these sorts of issues. So we're going to be working with them very closely over the next months and years.
And Congress too. And there's real patient impact here. Is that right, Jamie?
Yeah, I think a lot of members of Congress are having hearings about, we're talking about bigger waste, fraud and abuse. A lot of our, there's a small bad actors committing fraud, but also there's a system that forces every provider to spend billions on administrative tasks that don't improve care. So the congressional perspective of this is that, like I said, the members of Congress are having hearings saying that providers are billing for service they don't perform, fraud, providing unnecessary tests or procedures, abuse, and billing errors or overcharging. I think the funny thing from our perspective is that I have Hill staffers say, can you believe this fraud happened? We should eliminate the program. And I'm like, you found out about the fraud, you prosecuted it, that's how the system works. And so we need to educate members of Congress and policymakers that just because there is potential bad actors doesn't mean that the whole system should be thrown out. And we've had a lot of, Congress has talked about caring about the patients, but how does this impact the patients? There are stories about what about the grandmother waiting for a walker because her doctor needs to document a face-to-face visit from visit the last 6 months, or the dialysis patient in rural Alabama who before telehealth would have been put in an ambulance for a 90-minute drive to the nearest dialysis-ready hospital, and then waited 8 to 12 hours for treatment. So there's stories all throughout there that telehealth and these regulations, we need to give people better access to care.
Yeah, it's interesting. So as a former OIG enforcement attorney, there is a bit of irony here. These regulations were created to actually improve care delivery and also to prevent fraud. But really all it's doing is taking massive time away from all providers, which means they can't care for patients like they should. And it just costs so much money to do these sort of things. As again, I was a fraud attorney for years, and these regulations are not preventing fraud. And as Jamie said, we were able to find the bad actors. We really were. But these regulations need to be reformed because they're not doing what they're intended to do. All right, we're at 20 minutes.
Yeah.
Shall we just go right to close?
I think so.
Okay, fantastic. Daryl said it because he gets to close. Daryl?
Oh, sure. Well, anyone else have? No? Cool. So I think you really, if you look at our task force report, and I think what we're going to be talking about with HHS and Congress over the next weeks, months, and years, it's let's modernize Medicare statute and regulations so we really support care delivery and emphasize the point that the system, the way care delivery has evolved over the years, the rules and regulations need to catch up with that. So we're not looking backwards and spending time and energy on things that aren't adding value to the system and really helping patients achieve the best outcome they possibly can.
All right, I like that.
Yeah.
Yeah, and because by 2030, when all the baby boomers hit,
If we don't fix this by then, we're in for a world of hurt.
Yeah. And as I said before on these podcasts, at 2030, I'm in Medicare. So,
So now we're going to be evaluated on how.
right, if it goes poorly, I'll know.
No.
All right. Well, it's been a great podcast. As you mentioned earlier, this is going to be a huge focus for AMGA's policy team for the next 2 years. And we welcome all AMGA partnerships and comments on what regulations impede your ability to provide care and work with us as we try to get rid of as many of these as possible. And I guess that's it. All right. Well, we thank the audience for listening as always, and we hope you all have a very nice day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.